So today's topic will be disorders of the prostate gland. We will split it into two types, mainly benign disorders and malignant disorders of the prostate. So benign disorder of the prostate, can anybody tell me what are the common conditions that affect the prostate gland? Anybody has any idea? কেউ volunteer করবে? Prostated benign disorders কি হতে পারে? What do we mean by benign? বলো, what do we mean by benign disorder? Benign disorder কথাটার অর্থ কি? So benign disorder মানে যেটা খুব frankly বলে, it is not a malignant disorder, it is not cancerous, but still there are multiple diseases that affect the prostate gland, which basically form the bread and butter or a very common case for a urologist. Okay, let's start the topic then. So we will start with a small recapitulation of the anatomy of the prostate gland. Where is the prostate located in the human body? It is located at the junction of the bladder and urethra. Okay, at the junction of the bladder and the urethra. What are the relations of the prostate gland? Just as I said, it is proximal to the prostate gland lies the bladder neck and the bladder. Distally lies the membranous urethra. The prostate houses the prostatic urethra, and the prostatic urethra also has the opening for the seminal vesicle ducts. Okay. So if we see the cross section of the prostate gland, then it looks somewhat like this. The urethra and the seminal vesicle ducts traverse the prostate gland like this. Now, this is a very important classification, or what do we say, important division of the prostate gland that we need to know from the surgical point of view and also from the diseases point of view. What is this? So we have divided the prostate gland into lobes, in different lobes. So, or zones rather, not lobes, zones. So what are these zones? The zones are the transitional zone, the peripheral zone, the central zone, and the anterior fibromuscular stroma. So yeah, so you see this oblique part is the urethra. Okay, the urethra has the opening for the ejaculatory ducts. The ejaculatory duct passes through the zone that we call the central zone. The urethra is surrounded by the zone called the transitional zone. The anterior part of the urethra is surrounded by the peripheral zone, and anteriorly we have the anterior fibromuscular stroma. So what is important in this division is that different types of diseases affect different lobes of the gland normally. So we have seen that benign hyperplasia of the prostate usually affects the transitional zone, whereas malignant disorders of the prostate usually affect the peripheral zone of the prostate. What is the implication of such a generalization? The symptoms arising out of this, out of the hypertrophy, depends on where the hypertrophy is happening. So hypertrophy or increase in number of cells in the transitional zone causes increase in the tissues in this part around the prostatic urethra. So it gives rise to obstructive symptoms. It gives rise to symptoms which obstructs the flow of urine, whereas any tumor affecting the peripheral part of the gland does not give rise to any imminent symptoms, any definite urinary symptoms in the initial part of the disease. Okay. So first and foremost, the most important topic that we have to deal with today is benign hyperplasia of the prostate gland, BPH, যেটাকে সকলে প্রস্টেটের রোগ বলে commonly বলে. So this is actually growth of the elements of the prostate gland, usually in the transitional zone of the prostate. It happens by the action of testosterone and dihydrotestosterone. That means it is an androgen driven process. Acha, can you tell me what is the difference between hyperplasia and hypertrophy? Yes, and hypertrophy is increase in size. Okay. So, usually what affects is, it's a combination of hypertrophy and hyperplasia, but more so a hyperplastic process is involved in BPH formation. The estrogenic steroids in the presence of androgen promote this activity. Now, for this, to understand this, you have to understand that with increase in age, there is testosterone in the body eventually gets converted to estrogen. Now, there is upregulation of these androgenic receptors with age, because the final action is somewhat decreased with age. So, once the final effective action gets decreased, there is upregulation of receptors to increase this action. You get my point? And with this upregulation of receptors, these converted estrogens and other steroidogenic androgens, this act more to cause a hyperplastic process on the cells of the prostate. Which part of the prostate is affected? Both the glandular epithelium and the connective tissue stroma. Both these parts are affected. Okay. So, as I said previously, the transitional zone is mainly affected by this hormonal process, and other parts are also affected. So, what happens is, this is the bladder and this is the urethral outlet, and here lies the prostate. So, the increase of the prostate gland can happen in whatever format, it is not a fixed format. So, if the increase happens like this, the increase is obstructing the either lumen of the urethra or the exit pathway of urine from the bladder to the urethra, it causes an obstruction to the flow of urine. So, increase in the size of prostate in a certain configuration leads to an obstruction to the flow of urine, and this obstruction leads to secondary changes in the bladder musculature. The bladder musculature is always trying to overcome this obstruction and working more. So, what happens when a muscle is working more to overcome an obstruction? It is becoming thicker. So, once the bladder muscles are becoming thicker than normal, the bladder has this muscle should be this thick, but because of working more to overcome this obstruction, these muscles become thicker. So, this thicker muscle bladder, thick muscle bladder, it fails to increase in size when filled with urine. So, the compliance is decreased, it fails to collapse properly and it fails to increase in size. Khub muscular lokera হাত পা কম নাড়তে পারে না, খুব জিমে গিয়ে সেরকম ব্যাপার হয়. So, this very thick and muscular bladder tries to overcome this obstruction and effectively create a passage for the urine. In the process, it becomes muscular. In presence of this obstruction, persistent presence of this obstruction, what happens is, when the muscle contracts, the mucosa on this herniates out. In the same principle, surgery te jerokom hernial principle porecho, increase in pressure er jonno through the muscle gaps the mucosa herniates out to create something that we call a bladder diverticulum. So, the bladder wall thickens, muscle thickens, and this leads to what we call collectively as the secondary response to the bladder outlet obstruction. What happens to that? So, this obstructive component, the patient complains that the flow of urine is narrow. The flow of urine is often associated with straining in the abdomen. The patient has to use abdominal pressure for effectively passing urine. Now, since this component has, this feature has two components. One is a mechanical component, as I said, that is due to obstruction in the bladder neck or urethral lumen due to increase in the prostatic size. The other is a dynamic component. Uh, it is the contraction of the muscles in the bladder neck region around the prostatic region due to increased autonomic alpha adrenergic tone. Okay. So, these two components effectively lead to an obstructive process, and this leads to secondary symptoms like this. So, now we will come to the symptoms associated with the main obstruction and the symptoms associated with the secondary changes. What are the symptoms associated with obstruction? I just said the patient complains of a poor urinary stream. The patient complains that he has to wait for a certain period of time before the stream of urine starts, and that is medically called hesitancy. Okay. So, hesitancy, poor stream, abdominal pressure while voiding, and lastly post void dribbling. All these are called obstructive symptoms, and this obstructive symptom leads to secondary changes in the bladder wall and gives rise to storage symptoms. So, what are the storage symptoms? The storage symptoms are fun but not funny. So, fun means it increases in frequency of urine, increase in the urgency of urine. So, what is the difference between frequency and urgency? The difference is frequency is the increase in the total number of times the person has to go to the toilet to pass urine, whereas urgency means that the latency between the urge for urination and the time he voids gets shortened. The patient has to rush to the toilet when he gets an urge to urine, so that he does not leak urine into his clothes. And lastly, nocturia. Nocturia means increased number of urinary episodes at night. So, obstructive symptoms and secondary symptoms are separate. You can actually differentiate the predominant symptom and then choose the treatment strategy. So, as I said, what are the symptoms that the patient has when he is suffering from the problem of increase in size of the prostate? This is also collectively called lower urinary tract symptoms or LUTS, and it mainly comprises of all the things that I mentioned right now, that is the voiding symptoms and the storage symptoms. Voiding symptoms are equivalent to obstructive symptoms and the storage symptoms are the secondary symptoms. Okay. Other than this, a person with an increased size of the prostate may also present to a doctor with other symptoms like an acute retention of urine or a chronic retention of urine or hematuria. So, hematuria everybody knows, the patient will be passing gross blood in the urine. The patient will be able to see blood in the urine himself. Okay, so that is gross hematuria. So, now comes retention of urine, and we classify it into two types, acute and chronic retention. Does anybody have any idea what these two terms mean? What is the difference between acute retention and chronic retention? So, acute retention is that the patient was probably passing urine normally, and then suddenly the patient cannot pass urine anymore, and this is associated with pain in the abdomen and a suprapubic fullness. The bladder is full, the patient is having pain in the abdomen and cannot pass urine. So, this scenario is called an acute retention of urine, whereas a chronic retention of urine is a difficult disease to treat, because here the patient does not have any sensation that he is not being able to pass urine adequately. He is dribbling urine, there is constant dribbling of urine, and the patient has a feeling that he is passing urine, but the flow is poor, whereas the patient is actually holding back around 500, 700, 1 liter of urine in the bladder with no pain, no sensation of urination. Okay. So, it is very essential to differentiate between what is an acute retention and what is a chronic retention, because treatment strategies are very different for these two. Okay. So, how do we go about a patient who has come to us with any kind of symptom, any lower urinary tract symptom or a retention or whatever the symptoms I discussed? So, first and foremost, obviously you take a detailed history. You have learned this, to take a detailed medical history, past history, surgical history, all these things. After that, we come to clinical examination of the abdomen and genitalia. So, what is important in clinical examination of the abdomen and genitalia? When we are clinically examining a patient with urinary symptoms, our intention is to look for all the signs and symptoms in the patient which might lead to similar symptoms in the patient, and also we have to look out for those signs which are clinically relevant to the effect of this disease itself. So, we have to see whether the patient is having other features of outlet obstruction like phimosis, meatal stenosis, urethral stricture, anything of this sort which can also lead to a similar outflow obstruction. And two, we have to look for signs and symptoms which suggest this outflow obstruction is severe, mild, moderate. So, a full bladder, patient with a full bladder suggests that he or she is suffering from either acute or chronic retention of urine. So, when we are doing a clinical examination, we have to palpate the abdomen, we have to check the hernial orifices, because very frequently a person with prostatic issues have coincidental hernias, and then we have to check for other problems like I mentioned, meatal stenosis, phimosis, stricture, etc., etc. And lastly, but most importantly, we have to perform a digital rectal examination of the patient. What do we look for and how do we carry out a digital rectal examination? What is the process? What is the position of the patient? What are the factors that we have to, what? Sims. So, what is the Sims position? Okay, so the patient will be on one lateral side, usually left lateral side, and the knees or the upper leg will be towards the chest. What do you need to check before performing a digital rectal examination on a patient? Is there any local perianal pathology that precludes? Is there a perianal pathology that that in presence of which you should not perform a digital rectal examination? So, in presence of an acute anal fissure, it is better not to perform a digital rectal examination, because the patient might get up and slap you, because it is very painful. So, anyways, so coming back to the point, digital rectal examination we perform to see the consistency of the prostate gland. So, what do we actually see? We see whether the prostate gland is soft, whether the prostate gland is firm, or the gland is hard, and what is the approximate size of the prostate gland. That is an estimation, clinical estimation we make. What does this consistency of the prostate confer to? It confers that if it's a hard prostate, if there is a nodule on the prostate, then probably the patient will have to be evaluated for a malignant disorder of the prostate. If the prostate is tender, if the digital rectal examination, the palpation of the prostate per rectally gives a painful sensation, very painful sensation to the prostate, then other than the presence of a fissure, the other cause can be a prostatic abscess. Okay, acute prostatitis or a prostatic abscess. The prostatic abscess may be felt per rectally by a presence of a boggy sensation, just like abscess in other parts of the body. So, a digital rectal examination is very important when you are evaluating a patient with lower urinary tract symptoms for a male patient. Yes. So, now after doing a clinical examination, we come to investigations to confirm our diagnosis, to see whether the effects of the disease, what effect of the disease, and also to choose our treatment strategy. So, urine, routine and microbiological examination is very important, because any kind of lower urinary tract symptoms that I have discussed till now is possible in presence of a urinary tract infection. All the symptoms might be possible in presence of urinary tract infection. So, it is essential to rule out a UTI before proceeding with treatment for anything. Secondly, importantly, we have to perform a renal function test, PSA, ultrasound and a uroflowmetry. So, this ultrasound, this is a specific ultrasound looking into the kidney, ureter, bladder, prostate and a post-void residue. What do we mean by post-void residue? Post-void residue means in the process of ultrasound scanning, after completing a scan of the bladder, we see what is the volume of the bladder of the patient in full bladder. Document that finding. We ask the patient to go to the toilet, void and come back. So, the post-void residue should be in an adult male at least less than 100 at least. More than 100 is basically pathological. So, the patient should not be having, a normal person should not be having more than 20-30 ml post-void residue. So, this has very important significance I have discussed right now. So, a chronic retention patient and an acute retention patient can again be differentiated from this point. If a person after voiding has a large post-void residue, then we were probably dealing with a chronic retention. Now, what is PSA? Yes. So, what is prostate specific antigen and what is its importance? It's a tumor marker. Okay. So, prostate specific antigen is a very specific tumor marker. So, what kind of what is the use of a tumor marker essentially? Not just PSA, in general, what is the use of a tumor marker? How do we use tumor markers in clinical practice? So, tumor markers are essentially used for something we call as screening of a disease. The most important part is, especially for PSA and prostate cancer, we use PSA for screening the disease. So, what do we mean by screening? All these things we are doing for a patient who is having symptoms of some certain urinary symptoms and has come to the doctor with those urinary symptoms, and we are doing all these investigations. Whereas PSA can be used for screening for prostate cancer, and screening is used when the patient is not having any symptoms. What is the utility of screening for a disease? I think you've studied in community medicine, we utilize what we call the lead time. We diagnose a disease before it is having any symptoms to utilize the lead time and start treatment. Okay. So, PSA is important. I don't know whether nowadays it's the trend or not, but it was a very common short note in our times. Can you tell me another disease with which is also called PSA? No, I am saying this short form, if it comes in your examination as a short note, what will you write? Will you write this, or there is another disease which has an abbreviation of PSA? Pleomorphic salivary adenomas are also called PSA. So, anyways, so PSA is important in that. Yeah. So, what do we infer when a patient has an increased PSA, and how much increase is an increased PSA? So, generally we in our country we consider any PSA more than 4 to be an increased value. So, what does this mean? An increased PSA, what does it mean? It means that the person is having an increased chance of harboring a malignant disease of the prostate. But there are many confounding situations where PSA might increase. Can you tell me 1 or 2 factors which might increase PSA? When we are considering urinary symptoms, first we will consider those symptoms. You are right, it's not that you are wrong, but firstly, a patient with a urinary tract infection also might have an increase in PSA. acute prostatitis, prostatic abscesses are frequently involved with increase in PSA. Now, these are diseases which increase PSA. There are conditions or situations that where PSA might increase in itself, like the procedure of catheterization might increase the PSA value. Long distance cyclists might have an increased PSA value. Okay, so there are important factors that you need to rule out when considering a single value of PSA. So evaluation of a patient with lower urinary tract symptoms are done by this. We get the size of the prostate, the post-void residual urine, and any secondary changes in the bladder and secondary changes in the kidneys from this ultrasound. What do we mean by secondary changes in the kidney? That if the patient is having a very long-term obstruction, it leads to thickened bladder walls, which eventually leads to bilateral hydroureteronephrosis. Okay, so if the patient is having all these, it can be detected on this ultrasound. Now, what is an uroflowmetry? Uroflowmetry is a test which graphically represents the voiding pattern. Okay, whether the voiding pattern is obstructive or non-obstructive, and whether it is arising out of a prostatic obstruction or a obstruction due to urethral stricture can be assessed by reading the uroflowmetry curve. So, management of acute urinary retention. The patient has come to the emergency to you, which is going to happen in another say 5-6 months. তোমাদের পরীক্ষা কবে? জানুয়ারিতে হয় তো না কবে হয়? মে বা জুনে। আচ্ছা তোমরা এই সবে উঠলে। So anyways, the patient is coming to you with pain abdomen, distended abdomen and inability to pass urine for the last 8 to 10 hours. So that is acute retention of urine. How do you manage it? You manage it by doing a Foley catheterization. I would like to discuss, if I have time today, the ideal steps of how to perform a Foley catheterization. You should be taught these things in your practical classes. দুপুরবেলা classes হচ্ছে তোমাদের? মেডিসিনে দেখালে হবে না, সার্জনদের দেখাতে হবে যারা রোজ করছে। Anyway, so if I get time I will tell you. And suppose you cannot pass a catheter, তুমি catheter করতে পারলে না, then you have to do a suprapubic cystostomy. What is a suprapubic cystostomy? It's a bypass channel trans-abdominally. পেটের উপর থেকে you put in a bypass channel to create a tract so that the urine can come out. So this is management of acute retention of urine. Okay? দেখেছো suprapubic cystostomy করা পেশেন্ট দেখেছো? দেখো। So what happens is এই জায়গাটা বুঝতে পারছো? This is below the umbilicus. Umbilicus is somewhere over here. এখানে the tube has been passed directly into the bladder like this. You see, this is the anterior abdominal wall, this is the bladder, and a tube has been passed. This is an emergency procedure before we proceed to definitive management of this patient. Now, all these things are less frequently done. SPC are less frequently done for acute retention. We first do a Foley catheterization, and then we start medical management of the patient. A patient coming to your OPD with mild to moderate symptoms, not with retention of urine, for them also we consider medical management. So medical management is done by a group of drugs called selective alpha blockers. Commonly used drugs now are written on the board: tamsulosin, silodosin and alfuzosin, all having very similar effectivities. What does it do? So when we were discussing nature of obstruction, we discussed two types of obstruction. Yes, one is mechanical obstruction and two is dynamic obstruction. So alpha blockers mainly deal with the dynamic obstruction part. It relaxes the bladder neck, it relaxes the smooth muscles in the prostatic stroma, in and around the prostatic stroma, whereby slightly opening up this channel in case of obstruction. Okay, so what are the commonly mentioned side effects of these drugs? It's very frequently asked because this is very common. One is orthostatic hypotension and two is retrograde ejaculation. This happens very commonly and whenever you are prescribing this drug to any patient, you will have to mention these two side effects at least, that you will be suffering from orthostatic hypotension. So be careful when you are waking up and getting up from the bed. Wait for some time on the bed and then get up. You need to make the patient aware so that he does not fall and break his femur. Okay. So orthostatic hypotension and retrograde ejaculation are common side effects of selective alpha blockers. And the type 2 drug, second drug which are also used very frequently are the 5-alpha reductase inhibitors. So what does this do? This prevents the conversion of testosterone to the more potent dihydrotestosterone, in the process inhibiting prostatic stromal growth. Okay, so this works on the mechanical component. It prevents increase in size of the prostate and perhaps decreases the size of the prostate to some extent. Now, what are the side effects of these drugs? These drugs, because they are anti-androgens to some extent, they decrease libido, they cause erectile dysfunction and gynecomastia in some patients. So, what we do is we usually use a combination of these two types of drugs, 5-alpha reductase inhibitors and selective alpha blockers. So, a patient with lower tract symptoms not responding to medical management, then we think of surgical management of this patient. What is the surgical management indications? When do we prescribe surgery to this patient? When the patient, as I said, is not responding to medication. He is having persistent symptoms in spite of taking the medications regularly. Other indications are if the patient is having recurrent episodes of hematuria, recurrent infections, coincident bladder stone and a coincident bladder diverticula. Coincident bladder diverticula. Okay. So, if these things, if the patient is already having an indication for which he requires surgery irrespective of the medical effect, like a stone or a diverticula, then we proceed with surgery for the prostate as well, and recurrent hematuria and infections are also considered indications. Now, what are the procedures involved? What are the procedures commonly done? The most commonly done procedure is a transurethral resection of the prostate. What do we mean by transurethral resection? Here it's an incisionless surgery where we put in a scope through the urethra and we core out the prostatic tissue from the urethra. Now what we actually do is, তোমরা নারকোল কোড়া দেখেছো? Huh? So what we do is, you see this? So we've put in this scope. This is the prostate. We identify the region of the prostate and then we core out the obstructing part of the prostate. What is very important here to understand is, here suppose this is the prostate and this is the urethra. This is the enlargement of the prostate. Okay. So here what we do in this endoscopic surgery, we are removing only that part of the transitional zone of the prostate which is actually obstructing the flow of urine. Okay. This part we are removing so that we create a channel, an open channel between the bladder and the urethra. So what we are doing, we are removing this part so that this part remains open and the prostate does not cause an obstruction. So in spite of it being called prostatectomy, we are not removing the entire prostate in this procedure. We are only removing the obstructing part. When we are considering the other diseases, okay, laser enucleations, yes, there are multiple terminologies. For you, it is important to understand that enucleation is a technique. Enucleation means you remove the increased prostatic adenoma. It can be done by laser, it can be done by open, laparoscopic, robotic, many modalities. What we have to understand for this is that, again here we are not removing the entire prostate, we are removing the increased adenoma in this case, only the adenoma. Just it is similar to removal of the fibroid from the uterus and not the, when we are doing a myomectomy, we are removing the fibroid and not the entire uterus. When we are doing a fibroadenoma surgery, we are removing the fibroadenoma and not the entire breast. Similarly, in simple prostatectomy, open prostatectomy, we are enucleating the adenoma and not the entire gland. The target is to create an open channel, right? So this is TURP. You see the channel resected created. Just with this loop, we are trying to core out a channel, that is TURP. Okay, so this basically completes a basic understanding of the prostate disease, how to diagnose, how to screen for prostate cancer, how to evaluate, how to give medical management, what are the surgical indications and what are the surgical strategies, right? Now, we will shortly discuss prostatic abscesses and infection. So, acute prostatitis and prostatic abscess, they have very similar symptoms. It might lead to retention of urine associated with severe perineal pain, fever, symptoms of sepsis basically, with firm to tender prostate and a boggy sensation in case of prostatic abscess. Acute prostatitis, we deal conservatively with antibiotics, and if the acute prostatitis eventually leads to prostatic abscess, like an abscess anywhere in the body, we have to drain the abscess. That can be done either by a transrectal or a transurethral route associated with antibiotics for treating the infection. So, we will not discuss this in great detail. We will have to discuss something about this malignant disease of the prostate. So, as I said, malignant disease of the prostate affects which part of the gland of the prostate? Do you remember? It affects mostly it affects the peripheral zone of the prostate. So, what is the okay, so I'll go with the slides itself. So, this is a very this disease is common in elderly men, and with increasing age there is an increase in the prevalence of this disease. Okay, so why I described TURP and emphasized on TURP so much, because I wanted to emphasize this statement for you, that TURP for BPH does not prevent malignancy. Why? Because we are not removing the entire prostate. The prostate is still there. Okay. Now, for a malignancy, there is a scheme of things that we need to know regarding any malignancy that you will study. One is risk factors, pathological types, and then so on and so forth. So, risk factors for prostate cancer is very interesting. You will not find the most common risk factors that you blurt out for every other malignancy in prostate cancer. Smoking, alcohol, drinking, it's not there in prostate cancer. They are usually not risk factors. What are risk factors? Age. These risk factors are actually not in your hand. There are no modifiable risk factors. Okay. So, the risk factor is most importantly age, ethnicity. So, you will find prostate cancer in elderly people. You will find prostate cancer more in number, in very high frequency in African American men. Okay. Family history of prostate cancer is very important. It very frequently seen that father or the generation of father, they have prostate cancer, the younger generation can have increased risk of cancer. And lastly, one more needs to be discussed is obesity is now being considered to be one of the factors of prostate cancer as well. So, risk factor, what I need to emphasize is, if you are asked risk factor for prostate cancers, don't start by writing alcohol, smoking. These are usually not risk factor for prostate cancer. Now, pathological types. You might see a difficult diagram here, but 99% cases are adenocarcinoma, and the rest may be very small percentage of patients have other types of cancer which are tabulated. But we will now from now on discuss prostatic adenocarcinoma as cancer prostate. Okay. So, like every cancer, prostate cancers also have the tendency to spread, and the spread occurs by three routes mainly. What are the three avenues of spread? One is local spread, two is lymphatic spread, three is hematological spread. Okay. So local spread happens in the organs surrounding the prostate. What are the organs surrounding the prostate? The bladder, the urethra, the pelvic side wall, the seminal vesicles, so on and so forth. Okay. So since what are the sites of lymphatic spread? Firstly to the local lymph nodes and then to the distant lymph nodes. So what are the local lymph node groups around the prostate? Yes, obturator lymph nodes, then we have the external and the internal iliac lymph nodes, the presacral lymph nodes, and then we move out to the other secondary grade lymph nodes which we call metastasis. And then we have the blood spread. So the most common site of spread in prostate cancer or metastasis is axial skeleton. Okay. So most commonly we find metastasis in the lumbar vertebra. After lumbar vertebra, we also find metastatic lesions in the weight bearing bones, femur, etc. So why is this important? What is so special about the bony spread in prostate cancer? The special factor is its nature is osteoblastic. So what do we mean by osteoblastic? Bone forming. But in spite of being bone forming, this kind of a malignant spread or metastasis leads to fracture in the bones. So if it's bone forming, then why do we need to lead to fracture? Osteoporosis a fracture hoy, tai to? But here it's a bone forming, osteoblastic and osteosclerotic bole. So why is it bone forming and leads to fractures? Because bone strength basically depends on the architecture. It is bone forming, but it is not according to the architectural integrity that is required for bone strength. So osteoblastic hoy সুবিধেটা কি? What is the utility? I mean, advantage of getting this description? Osteoblastic, we can see on X-ray, it's more whiter patches. বুঝতে পেরেছো? So if a patient comes to you with no prostatic symptoms but with back pain and you do a X-ray of the spine and you see the spine is having white patches, you have to be clever enough as a physician to think retrograde for an elderly person. This might be a metastasis from the prostate because prostate cancers are often asymptomatic, mostly asymptomatic. When you get a symptom for prostate cancer, you have to assume that it has already spread. It is not a localized disease anymore. It has spread to some other organs so that symptoms have started to arise. Okay. So that there lies an importance. Orthopedics people get an X-ray done. If they see it's a sclerotic or osteoblastic lesion, then we have a list of cancers which can be silent and metastatic component is an osteoblastic or a sclerotic lesion. Okay. So this is the mode of spread. I am not going into very details for the TNM staging. I don't know whether it's important for you. It's just clinical staging of the tumor, node and metastatic lesions. You go through it. Now this is a very interesting thing. It is not commonly done for other cancers, that we have a scoring system for the histopathology. Okay. So how do we come to this? Yes. So we come to this, I will come back to the scoring system. So a person we are suspecting, how do we suspect a patient with prostate cancer? There are two ways. One is we do a screening with PSA. Two is that we get a raised PSA in a patient with minor lower tract symptoms. Three, as I described, I get some symptom, retrograde, we assume that this might be a prostate cancer, and then we evaluate the patient for prostate cancer. So pathological bone fractures in elderly males, spine fractures in elderly males, All these must make you think back whether he is having a primary site of malignancy. So, like the previous disease, we are doing a regular clinical history and examination, digital examination, serum, PSA and all, urine analysis. With that, once we consider that this is a patient might be requiring, might be having prostate cancer, we do a transrectal biopsy. Okay, an ultrasound guided transrectal biopsy. With this biopsy report comes with this scoring system. Okay, so this biopsy report gives us two kinds of information. One is whether this is a malignancy. Two is whether this what kind of malignancy, usually an adenocarcinoma. And three, it gives us this scoring system. This scoring system is based on low power microscopic findings, architectural findings of the prostate, and basically helps us to grade the prostate disease into high, moderate, low risk disease, okay, depending on the nature of the architectural pattern. So, this is important, go through it. So, once we know that this patient is having a malignancy from our biopsy, then we have to stage the patient. Any patient with a malignancy, we have to do a staging of the malignancy to see whether this is a localized disease, or this is a locally advanced disease, or this is a metastatic disease. Okay. So, how do we do that staging? We basically do that local staging by something we call a multi-parametric MRI. Okay. So, MRI, to be specific, we do a contrast MRI of the prostate gland to see whether there is a local spread of the disease, where what is the relation of the disease part of the prostate to the seminal vesicles, pelvic wall and other local structures. We do a bone scan to see if there is a bone metastasis, it is a technetium bone scan, and lastly we do a dedicated PET scan for the prostate. It is most commonly we are doing nowadays is a PSMA PET scan. So, with these three scans, we get a conclusive evidence of whether this malignant disease of the prostate is localized, locally advanced, or metastatic. So, once we have this, this is the way a transrectal examination and biopsy is done. Okay, transrectal probe is introduced, and then we target the prostate with a needle like this to take a biopsy. Can you see? Transrectal probe, and through the transrectal probe we put in a biopsy gun. Okay. So, we have now classified the disease into localized, locally advanced and metastatic. Now, regarding the treatment options, what are the treatment options for this malignant disease? If the disease is localized, absolutely localized to the prostate with no lymph node spread, with no local extension and no metastasis, then we have basically three options to treat this disease. One is, if it is a very low risk disease in a very elderly individual with no symptoms at all, we can do something which is called either a watchful waiting or an active surveillance. In these two things, we are not treating the patient. In watchful waiting, we are waiting for the patient to develop any symptoms, and we intend to treat only when the patient is having symptoms. And in active surveillance, we are trying to evaluate whether the malignancy is dangerous enough to cause effects, to spread in the body. So, we are constantly evaluating the patient whether the size of the tumor is increasing, whether the PSA is increasing, this and so on and so forth. So, watchful waiting and surveillance, essentially we are not treating the patient, but in active surveillance we are trying to evaluate whether the malignancy is increasing or not. And the other two options are a radical prostatectomy and radiotherapy. So, this radical prostatectomy is again another type of prostatectomy. It is totally different from the TURP or the transurethral resection that I described. Here, we disconnect the bladder neck from the entire prostate and the urethra from the entire prostate. Okay, so this whole prostate is removed. We are left behind with a bladder neck and a urethral opening. Now we join this bladder neck to the urethra directly and remove the prostate. That is radical prostatectomy, and that is done in case of a malignant disease of the prostate, not for benign diseases. Okay, this can be done by open surgery, laparoscopic surgery and robotic surgery. And number 2 is radiotherapy, where we target the prostate with radiation beams to treat. Now, the above 2 treatment modalities have almost equal treatment results. The details of where to go for what is actually beyond your scope, but still a younger patient with a longer lifespan, we usually promote to opt for radical surgery, whereas slightly elderly age group or lesser expectancy of life, we tend to go with radiotherapy. Now, supporting this kind of treatment for locally advanced diseases, we have a very important treatment strategy that is less frequently found in other cancers, that is a hormonal treatment. Okay, so hormonal treatment is basically backbone of the therapy for prostate cancers. Why? Whatever other modalities of treatment we use, eventually in cases of recurrence or supporting therapy, we have to use androgen deprivation therapy. So androgen deprivation therapy, what are the options? Androgen deprivation can be done by surgical method. What is the surgical method? It's the method of castration where we remove both the testes. Okay, bilateral orchidectomy. It's a very commonly practiced method in our country because it is the cheapest modality. Other than that, we have medical options. Medical options, there are multiple drugs and categories like GnRH analogs, GnRH antagonists. Please go through these drugs, these are important. How do they work? So this basically, what does it do? It causes a temporary medical castration. As long as we are using the drugs, till then the results are similar as castration. Okay, and then we give a combination of androgen deprivation drugs, so on and so forth. So androgen deprivation therapy in prostate cancer is actually a very big topic. I don't have time to discuss in detail today regarding it. It is also the main component of therapy for a metastatic disease. Okay, so patient coming with metastasis, the main therapy is often an androgen deprivation for palliation of symptoms. Now lastly, a patient might come to you in the third category that I described with some specific symptom like bone pain or fracture risk or spinal cord compression, and from there you have diagnosed a prostate cancer. For them, the main intention is to treat for metastatic disease with androgen deprivation, and along with that we give therapies dedicated or targeted to the primary symptom. Like for cord compression, we give steroids, we do surgical stabilizations of the spine. For increased fracture risk, we give calcium, vitamin D, bisphosphonates, now teriparatide, parathormone, etc. And for bone pain, we give dedicated analgesics, etc. So this is in a very nutshell cancer prostate, adenocarcinoma of the prostate. So what we should know at the end of this class is what is screening by PSA, how do we diagnose prostate cancer by doing a transrectal biopsy, how do we stage prostate cancer by doing MRI of the prostate and a PSMA PET scan, what are the risk factors or etiological factors of the prostate cancer? They are not tobacco, smoking, alcohol, they are rather age related, obesity, hereditary and ethnicity. Okay, and treatment in a basic nutshell comprises of multi-modality approach. This is the term that you should know. Prostate cancer, there is no one treatment, we always use combinations of one or two things. And what are those options? One is radiotherapy, two is radical prostatectomy, 3 is hormonal therapy, and now eventually every disease is eventually leading into immunotherapy. We are having options for immunotherapy and chemotherapy as well.